Welcome back to Emergency Insights. I'm James Carter, and joining me today is Dr. Janet Liu, a leading expert in emergency medicine. Today, we're tackling a critical topic, the management of carbon monoxide poisoning. Dr. Liu, thank you for being here.
Thank you, James. It's a pleasure to be on the show.
Let's start with the basics. A patient presents with suspected carbon monoxide poisoning. What is the immediate priority for treatment in the emergency department?
The immediate and most crucial step is to administer 100% oxygen. This should be done without delay using a non-rebreather mask, non-invasive positive pressure ventilation, or a high-flow nasal cannula. The goal is to rapidly displace carbon monoxide from hemoglobin. Oxygen treatment alone significantly shortens the half-life of carboxyhemoglobin from over 5 hours to about 80 minutes. This is the cornerstone of initial care for all patients.
That makes sense. Now, let's address a more contentious topic, hyperbaric oxygen therapy. Is this a standard treatment for all patients with carbon monoxide poisoning?
That's an excellent question, James. The use of hyperbaric oxygen therapy, or HBOT, is quite controversial. While it further reduces the half-life of carboxyhemoglobin to as little as 15 to 30 minutes, its routine use is not recommended for all patients. The clinical benefit, particularly regarding long-term neurological outcomes, remains uncertain. Current evidence is not clear enough to support its universal application.
So, if it's not for everyone, for which patients should we consider contacting a hyperbaric oxygen center?
There are specific indications where HBOT should be considered, ideally within 6 hours of the poisoning. Key criteria include a coma or any altered level of consciousness, persistent neurological deficits, metabolic acidosis, or evidence of end-organ ischemia, such as ECG changes or elevated troponin levels. We also consider it for specific patient groups, including any pregnant patient with a carboxyhemoglobin level greater than 15% and those not responding to initial 100% oxygen therapy. It's crucial to remember that clinical presentation and symptoms can be more telling than carboxyhemoglobin levels alone.
You mentioned pregnant patients. Is there a different threshold or consideration for them?
Yes, absolutely. Pregnant patients require special consideration due to the heightened susceptibility of the fetus to carbon monoxide toxicity. Fetal hemoglobin binds to carbon monoxide more tightly than adult hemoglobin, so the fetus is at greater risk. For this reason, a lower threshold for HBOT consideration is often used. We would typically consider HBOT for pregnant patients with a carboxyhemoglobin level above 15% and those not responding to initial 100% oxygen therapy.
Finally, what's a key message healthcare providers should take away regarding patient follow-up and management after initial treatment?
The most important takeaway is to inform patients about the risk of delayed neurological sequelae. These can manifest as cognitive changes or other neurological symptoms, sometimes weeks after the initial exposure. Follow-up is critical for any patient who shows cognitive or neurological changes during their recovery. We must ensure these patients are monitored and receive appropriate ongoing care to manage any long-term effects.
Dr. Janet Liu, thank you for sharing these crucial insights. The clarity you've provided on this complex topic is invaluable.
Thank you, James.
And that concludes another episode of Emergency Insights. We hope this discussion helps you in your practice. I'm James Carter, and we'll see you next time.